run uh, faculty lectures for this session. Today, faculty lecture will be peripheral vascular disease and endovascular procedures. Our faculty today will be Professor Orko Rai, who is Professor of Surgery at North Bengal Medical College. So, Professor Rai, you can share your slide and start,
Okay.
please.
So to start with peripheral vascular disease and endovascular procedures, mainly the peripheral vascular disease, initially there are 2 to 3 types of diseases are there. Number one is atherosclerotic disease, then is Burgess disease or thromboangiitis obliterans, and there is also Raynaud's disease. Now a term has come up that is peripheral arterial occlusive disease and also lead. Lead is what is commonly termed nowadays is lower extremity arterial disease. So whenever we are talking about peripheral vascular disease, the thing which will be restricted us for the discussion is lead, that is lower extremity arterial disease, and mainly the atherosclerotic disease, which is nowadays the more prevailing. So we'll stick to this type of disease only for the atherosclerotic disease, for which endovascular procedures are coming up again and again. And I will also give a brief account of Burgess disease. So it refers mainly to peripheral arterial disease caused by atherosclerotic narrowing occlusion of limb arteries. Commonly affects lower limbs, what I have already said, leads to ischemia and tissue damage. So we'll stick to definition, clinical features, investigations, management, endovascular management. What is the definition? It is a condition in which blood flows to the limb, most often legs, is reduced due to narrowing or blockage of arteries, usually due to atherosclerosis. So this is the definition of peripheral vascular disease. So this is one picture showing there is a blood flow is reduced due to initially uh, plaque around the blood clot, pure blood flow, narrows arteries are narrowed, then blocked, and tissue below peripheral artery is damaged. This is the whole picture of peripheral arterial disease due to formation of arterial plaque. So this is the normal artery and this is the atherosclerotic artery with lumen is reduced due to deposition of atherosclerotic plaque, thus producing decreased blood flow. So, what are the risk factors? For all the peripheral arterial disease, these are the common risk factors. Though there are difference in ages when you consider thromboangiitis obliterans and for atherosclerotic disease. So, number one is smoking, then is diabetes mellitus, then hypertension, hyperlipidemia, old age, obesity, and sedentary lifestyle. Now, these are all comes in a horizontal or vertical manner, that obesity and sedentary lifestyle associated with diabetes mellitus and also hyperlipidemia. Even smoking is also a cause of atherosclerotic plaque formation due to, as nicotine is also a thing which can damage the intima of the arteries, that also causes increased chance of atherosclerotic plaque formation and deposition. And that is also called, that is old age. Old age is another factor where atherosclerotic disease can come again and again. So these are the risk factor for peripheral vascular disease, mainly atherosclerotic diseases. Now, what are clinical features? That is intermittent claudication, that is calf pain on walking relieved by rest pain. It is due to advanced disease. There may be cold limb, hair loss, shiny skin, non-healing ulcers, gangrene, reduced or absent pulses. So when you can get a long case in case of in peripheral vascular disease. So one thing you must know how to take the history of the patient, because in this type of patients they actually ignorant of their pain. So you have to ask what type of pain is there, what is the site of the pain where the pain is started, how long the patient can walk before the pain starts, and when the pain is reduced after walking for some distance or not. Initially, pain will be reduced if you walk after some time, but then at, if the disease progression is worsening, then even after walking for some time, pain will not reduce and it will come even in rest, which is called rest pain. So intermittent claudication is an important thing to assess the condition of the patient for how the peripheral arterial disease has progressed or not. Above that, there are some other investigations, other things, but these are the things that site of the pain, initiation of the pain, how the pain is relieved, whether the pain is being reduced even after walking for some distance or not, and even the pain is coming after walking for some distance and also in the rest. So there are two classification. One is Fontaine's and one is Rutherford stages. Those stages of Fontaine classification, initially it was a stage 1, 2, and 3, 4. Nowadays, it has been subdivided. The stage 2 is 2A, 2B. Stage 1, it is asymptomatic. In stage 2A, mild claudication, that is pain after walking for more than 200 meters, it is coming. So it is stage 2A. In stage 2B, moderate to severe claudication, pain is coming after walking for a distance of less than 200 meters. Stage 3 is ischemic rest pain, and stage 4 is ulceration or gangrene. Now, stage 3, late stage, and also stage 4, these two constitutes critical limb ischemia. Above that, stage 2A, 2B, it is chronic limb ischemia. Stage 3 and stage 4 is critical limb ischemia. But Fontaine classification is a not good tool that assess the properly the patient's condition of the patient's limb. So for that, we have to take up another classification that is known as Rutherford classification stages for chronic limb ischemia. Rutherford classification stages also have uh, acute limb ischemia, which I have not mentioned here, but Rutherford classification of stages for chronic limb ischemia, that is category 0, that is asymptomatic, grade 1 or category 1, mild claudication even in grade 1 is category 2, that is moderate claudication, grade 1 category 3. So under grade 1 there are 1, 2, 3. That is grade 1 is refers to also Fontaine classification. That is under font, which is grade 1 in Fontaine classification. In Rutherford classification, there are only category 1, 2, and 3 regarding to mild claudication, moderate claudication, severe claudication. These are things which actually I am come to later. There are assessment according to ABPI. ABPI more than 50, ABPI less than 50. If mild claudication means even after walking, it is ABPI is more than 50, moderate just 50 or just below 50, but in severe claudication it is below 50. And in ischemic medicine is already done told. And grade 3 is category 5, that is minor tissue loss along with that changes of ABPI, and grade 3 which is category 6 also. So what is grade 3 in Fontaine classification, that can get 5 or category 6 in Rutherford classification, that is minor tissue loss, non-healing ulcer and focal gangrene, and category 6 major tissue loss. So in which is grade 0, that is same for both. For grade 1 there are category 1, 2, 3. For grade 2 there is category 4, and grade 3 category 5 and 6. These are according to the claudication distance. Number 2 is ABPI and treadmill. These are the three things which takes into consideration why while we are going for Rutherford stages. So this is the picture, that is how the pathology inside the uh, pathology for the patient. So mild claudication, moderate claudication, severe, minor tissue loss, non-healing ulcer, and major tissue loss. So this is the picture. So what are the key characteristics of these Rutherford staging? You should know. Uh, Clinical utility used to determine prognosis with higher stages, that is 4 to 6, indicated significantly higher risks of mortality and amputation. Assessment combines clinical symptoms with objective findings such as ABPI, what I have already told, Doppler waveforms, and pulse volume recording. So these are the things, because in case of category 3 and 2, initially the pulses are feeble, and even the pulses cannot be palpable. So again, I am going to this lecture. So in case of claudication, so they use ABPI, that is 234, that is what is whether it is less than 50 or more than 50. And in case of 5 or 6, they also use the palpable pulse, that in whether it is feeble or there is no pulsation. So these are the things which is included in the Rutherford classification of stages of a case of peripheral vascular disease, mainly due to atherosclerotic changes. So this is the picture of peripheral. So again, artery nerve plaque, there is cramping, aching, tingling, or numbness in lower leg. So one thing I will add, why there is a reduce of pain in the initial stages, because there is an accumulation of substance P which irritates the nerve endings, which causes pain during the initial stages of uh, our peripheral vascular disease. As the patient walks, there is increased blood flow, and that wash away the accumulated substance P, and again the irritation is lost, and so pain will be relieved. But as long as this progression is going on, so lesser amount of blood flow, so more less chance of washing away of substance P, so the pain is remains. So what are the investigations? Ankle brachial index, Doppler ultrasound, nothing to tell about that. And it is the there is frequency and signaling, the alteration of which, and the waveform which will dictate whether there is a peripheral vascular disease or not, CT angiography or MRI angiography, and digital subtraction angiography. This is an invasive procedure, and still now it is, and though MRI angiography is replacing it is nowadays, but still it is gold standard, but MRI angiography is replacing. And the initial thing for the investigation part after the history and assessment clinically, ankle brachial index is the key cornerstone for diagnosing the peripheral vascular disease, and also whether the patient is in having the chronic limb ischemia, or there is another thing called critical limb ischemia. Critical limb ischemia should be dealt urgently. So, so what is, I am just reading it out, a continuous wave UV signal is transmitted from the probe to an artery, and the reflected beam is picked up by a receiver in the probe itself. The change in frequency of the reflected beam as compared to the transmitted beam is due to Doppler shift resulting from the reflection of the beam by moving blood cells. The frequency change may be converted into an audio signal, and in arteries, a pulsatile sound typically results. The Doppler signal indicates moving blood, but does not necessarily indicate that the blood flow is sufficient to prevent limb loss. So for assessment, another, so now what is ankle brachial pressure index? It is the division of systolic BP, blood pressure ankle of the ankle, by the systolic blood pressure of the brachial artery. So this is the index. So value less than 0.9, that is some indicates some degree of arterial obstruction. 0.7 to 0.5 indicates claudication. Less than 0.3 suggests imminent gangrene. Normal values 0.9 to 1.1 at rest are misleading in calcified arteries, as they are non-compressible and may give false normal values, mainly diabetes, or and also in case of advanced atherosclerotic disease. So you have the uh, features of PVD, but ABPI is normal. But you also think of that the disease has progressed to such an extent that calcification has already ensures, and there is no compressibility of these arteries, and hence there is a chance of progress from disease to critical limb ischemia, and you have to manage accordingly, that you have to go for MRI or CT angio or even digital subtraction angiography. So this is the picture how you can assess. This is the handheld Doppler. I have a video, but so in normal individuals that has to be taken. ABPI increases after exercise, whereas in arterial occlusive disease it decreases. So this is the thing you should always keep in your mind while assessing and thinking of any peripheral arterial disease. So among the investigation, there is a differentiation features between CT angiography or MR angiography. So CT angiography is another modality used to image arterial diseases. It does have some pitfalls such as the requirements for large amounts of contrast media, the necessity of synchronizing the image acquisition with the media administration, and the need for an upgraded CT scanner with post-processing technique to reconstruct helpful images. However, advances in technology now allow three-dimensional and four-dimensional reconstructions, providing temporal information. MRA is useful for imaging large and small vessels. Although it was initially considered to provide inadequate images, this is no longer the case with improved imaging capabilities. MRA can be used not only to diagnose but also to help plan the type of indicated intervention, because MR angiography can also delineate whether there has been development of collaterals or not. So collaterals are the things which dictates the treatment options. It also give us the planning for operation or amputation. So this is the another thing that MR angiography will help in assessing the condition of the arteries and also can lead us whether we can go for amputation or not. Now coming to management, there are initially medical management like antiplatelets, statins, smoking cessation, control of diabetes and blood pressure, and supervised exercise program. These are the initial medical management which you should give to the patient. Regarding within the limit of pain, you should start graded exercise, which improve the condition of the patient by opening a collateral. So exercise should be graded within the limit of the pain and should be supervised. Surgical management, mainly bypass surgery for long segment occlusion or failed endovascular therapy. I'm coming later to endovascular therapy and arterectomy in selected cases, and advanced therapies in critical limb ischemia like amputation if limb is not viable, stem cell or gene therapy, which is still in the experimental era. Now, coming to endovascular procedures, though it is a domain of radiologists nowadays because there are intervention radiologists, and there is also we have a vascular surgeons who are also performing this type of endovascular procedures. So I'm not going to the very details what are different types of endovascular procedures, which is a minimum what is a basic things and definition. So it is mainly the minimally invasive catheter-based procedures performed through femoral in case of lower extremity and radial artery in case of upper extremity. And aim is to restore arterial patency, alternative to open bypass surgery. So with the invent of endovascular procedures, different type of bypass surgeries like femoral bypass, femoral bypass are nowadays can be avoided if can be taken up in the ideal stages, and it can also halt the disease process with follow-up and proper lifestyle modification and exercises. So what are the indications? Indications are lifestyle limiting claudication, that is normal day-to-day procedures cannot be done. There is a severe rest pain, critical limb ischemia, short segment stenosis. When the, in earlier days, in case of short segment stenosis, these bypass operations are very much useful, but nowadays it can be converted to endovascular procedures. High surgical risk patients and also acute limb ischemia, they can also be treated with endovascular treatment with some modifications. So there are different types of endovascular procedures. Percutaneous transluminal angioplasty. A balloon is inflated inside the artery to compress plaque and widen the vessel. Next is stenting. A metal mesh tube, that is bare metal or drug eluting, is placed to keep the vessel open. Next is atherosclerotomy. Specialized tools are used to cut or shave plaques away from the artery wall. Intravascular lithotripsy uses sonic pressure wave to break up calcium and vessels. There may be thrombolysis and thrombectomy. And nowadays, which is now under evaluation and also coming up more, that is drug coated balloon and drug eluting stent. Increased use of drug eluting stents and drug coated balloons has improved long term patency rates. Nowadays, these things are used more and more. It is also useful for the patient, though the cost is more. So this is a picture of balloon catheter introduced to the femoral artery, and after that it has been inflated. So this is a guide wire with balloon. A guide wire with a dilated balloon is passed through the catheter in the narrowed artery. There is an atheroma. Now the balloon is there. The balloon is then inflated to open the narrowed artery, and the stent expands around the balloon. The balloon is removed now, and the stent is placed in that place to keep the artery open. So this is a type of blood vessel is treated with balloon angioplasty and stent. So this is the actually guided procedure, and nowadays also vascular surgeons are also doing these procedures. So this is the condition, how it looks now, a narrowed artery, and we have placed stent after inflation of the balloon. So what are the advantages? As you know, it is minimal invasive, can be done or done usually with local anesthesia. Hospital stay is less. Pain after the procedure is less. It can be repeated. If the stent is blocked, it can be taken out and even can be replaced. Suitable for elderly and comorbid patients. So what are the complications? Complications are hematoma, vessel perforation, dissection of intima, that is bad, that lead to distal embolization, contrast nephropathy, that is a contrast, and what we have already told, restenosis. So these are the complications of endovascular procedures, and this can be dealt. And the dangerous among these complications are vessel perforation, dissection, and also distal embolization. Contrast nephropathy can be taken care of nowadays properly, and restenosis can also be treated if there is no other problem with taken out of the with stent replacement. So nowadays there are more and more studies coming up with the endovascular procedures, and more things are being implemented in this area. So this is a comparative study with endovascular therapy with open surgery. Endovascular is a minimally invasive, can be local anesthesia is used. It is fast recovery and moderate patency. So, but in case of open surgery, only one thing is advantageous, that is better long-term patency. Otherwise, it is a major surgery. It needs general anesthesia. Recovery is slow as compared to endovascular therapy. But the one aspect of open surgery is that is it can ensure better long-term surgery in spite of all other disadvantages over endovascular therapy. So now I am coming up for a brief discussion of Burgess disease, which is thromboangiitis obliterans. Progressive non-atherosclerotic segmental inflammatory obliterate disease of small and medium-sized arteries and veins of the distal extremities that affects young smokers. Now, what is the main difference between this Burgess disease with atherosclerosis? In TAO, it is less than 40 years. Atherosclerosis more than 50 years patients. Almost always smoker. In case of atherosclerosis, they are frequently smoker. There is other atherogenic risk factors are rare in case of TAO, but here in atherosclerotic disease, other risk factors are common. Distribution is mainly in distal extremity in TAO, but in atherosclerosis, distribution proximal, even extremities, cerebral camera are used. Extremities is equal to mainly upper extremities is also involved in case of TAO, but is rare in case of atherosclerosis. Lower extent coordination, foot is mainly involved in case it is very important in Butter disease. Pain is at the level of foot. In case of atherosclerosis, pain is in the calf and thigh mainly. And superficial trauma and phlebitis is common in case of TO. It is not seen in atherosclerosis. So these are the differentiating features in case of atherosclerotic disease, and also and with thrombo, and that is obvious. What is the main important is the only there is a pain in the foot, whereas it is pain in the calf and thigh, and superficial thrombosis is not seen in case of atherosclerotic diseases. So what I have already told, that is more almost exclusive in young male smoker. So there is a epidemiology is age 20 to 40 years. Sex male are more affected than female, though rising in females due to smoking habits. Common in Middle East, India, and Southern Asia. Strong association with tobacco use. Etiopathogenesis, smoking, nicotine, and other toxins cause endothelial injury leading to inflammation and thrombosis. Decrease disease improves only after complete cessation of tobacco. Now, immune mechanism, that is due to hypersensitivity to tobacco extracts, circulating anti-endothelial antibodies, and genetic predisposition, mainly associated with HLA-A9 and HLA-B5. Pathology is segmental inflammatory thrombotic process involving small and medium-sized arteries and veins, mainly tibial, peroneal, and radial and ulnar. Thrombosis with micro abscesses in vessel lumen. Preserved internal elastic lamina distinguishes from atherosclerosis, which is involved in case of atherosclerotic disease, which I told. Adjacent veins and nerves are often involved. That is known as vascular triad. Sites commonly affected are in lower limb, tibial, peroneal, dorsalis pedis arteries, and in upper limb, radial and ulnar arteries. And this disease is often bilateral. Now, there is a Shayana criteria for clinical staging of Butter disease. When we call it Butter disease, the criteria which should be met according to this criteria, that is, the patient should have smoking history with onset before the age of 50, infrapopliteal arterial occlusion, upper limb involvement or migratory thrombophlebitis, and no other atherosclerotic risk factor. These are the points or criteria which should be made to stamp the disease as a Burgess disease. So this is the criteria which is been postulated for the definition and diagnosing clinically a Burgess disease. So the clinical features are limb ischemia, that is limb ischemia, that is intermittent claudication in the calf or foot pain on walking, rest pain, especially at night, relieving hanging foot over bed. It's a typical picture which you can see in the wards if a Burgess disease patient is encountered. Coldness, numbness, and paresthesia of the affected limb. Trophic changes, that is thin, shiny, hairless skin, brittle nails, ulcers and gangrenes at the tips of toes or fingers, Raynaud's phenomena, episodic digital pallor and cyanosis due to vasospasm. Superficial thrombophlebitis, migratory thrombophlebitis, characteristic features, and absent peripheral pulses, dorsalis pedis and posterior tibial pulses, absent, femoral, usually palpable. Now, investigation, again, there are non-invasive investigation and invasive Doppler study or Doppler duplex scan, ankle brachial index, that is as thing that is it is a even a feature of chronic limb disease, ischemic disease. So it is reduced to less than 0.5. Allen's test for the upper extremity. There is imaging, conventional or CT angiography, segmental occlusion with cross-hook collaterals are seen. Distal arteries are affected, proximal arteries are spared. So usually normal laboratory finding. So, but you also has to rule out diabetes, autoimmune disease, and also hypercoagulal state, because hypercoagulal state can also lead this type of pain. Coming to management part, absolute smoking cessation, most important and only curative measure. Even minimal tobacco use can cause relapse or progression. Medical therapy, mainly vasodilators, that is nifedipine, cilostazol, pentoxifylline, which is used initially for the symptomatic relief. Antiplatelets, that is anticoagulations, though limit benefit is limited. IV prostaglandin analogs, nowadays it can is given iloprost, may improve distal perfusion. Analgesics for pain and wound care for ulcer and gangrene. These are treatment which can be now. That surgical treatment, lumbar sympathectomy, so causes arteriolar dilatation, relieves rest pain, promotes healing, indicated in rest pain without gangrene. Then arterial bypass, rarely feasible due to distal disease, lack of target vessel, amputation. For irreversible gangrene, we can do amputation or in case of infection. Aim is minor amputation if possible, toe or transmetatarsal. Now, newer adjunctive therapies are there. That is stem cell therapy, that is therapeutic angiogenesis, though is experimental, and spinal cord stimulation that cause pain relief and improve circulation. Prognosis. Now, progression depends entirely on smoking cessation. With continued smoking, there is recurrent episodes, progressive gangrene amputation, complete abstinence causes stabilization and improve the condition, though sometimes. So, in conclusion, peripheral vascular disease is a common cause of limb ischemia. Early diagnosis prevents limb loss. Endovascular procedures are effective and safe, but best result when combined with medical therapy and lifestyle modification. Thanks.
Uh, okay. Thank you, Professor Rai, for nice overview of this peripheral vascular disease. In fact, in earlier days, Barjas was a common disease, and that was a long case given in the exam. But nowadays, we rarely find thrombosis obliterative disease, and most of the disease which are being kept in the examination will be atherosclerotic vascular disease. So don't give a prompt diagnosis of Barjas disease in patient population who are in the ward, particularly 50 plus patients. Okay, so anybody can ask any question. So if you have any question for clarification, you can ask. Another criteria for Barjar was Raynaud's phenomenon, because one criteria for defining Barjar was in addition to the arterial disease, vascular disease, and patient has got Raynaud's phenomenon. So patient may have Raynaud's phenomenon as part of Barjar's criteria. But now you are saying that this criteria does not include Raynaud's phenomenon as one of the criteria. So, if there is no question, you can conclude today. Thank you, Professor Rai, for nice presentation of this. Because these are very important for your theory answers, where you can write a very brief theory outline for the vascular diseases. Mhm. Thank you. Thank you very much. We conclude today. Thank you.